Hospital and health system trustees are promoting value in their communities by tackling societal factors that influence the health and well-being of their communities. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hitterly, senior writer with AHA. Joining Priya Bathija, AHA's Vice President of Strategic Initiatives, in this two-part podcast are three trustees. Bill Menner, Chair at Unity Point Health, Grinnell Regional Medical Center, and Trustee at Unity Point, Des Moines. Dr. Winfred Parnell, Chairman at Parkland Health and Hospital, and Carolyn F. Scanlon, Vice Chair at Penn Medicine Lancaster General Health and Trustee at Penn Medicine. Though each of them come from a different type of hospital, together they will discuss how their boards have made community health a strategic priority for their organizations, and how they prioritize, collaborate, measure, and fund these important efforts in partnership with community stakeholders.
Thank you, Tom. On this podcast, we're going to continue to discuss how trustees can make community health a strategic priority for their organization and how they can move forward on these efforts with others in their communities. On the first part of this podcast, our guests discussed what conversations need to take place in the boardroom, the impact COVID-19 has on these conversations, and the data needed to support conversations around social needs of patients and the broader social determinants of communities. Before we get started on our second part of the podcast, I wanted to share, as I did on the last podcast, that there is no one right way to do this. There is also no wrong way. As you will continue to hear from our guest experiences, the way forward is the way that works best for your community. Thank you for joining us again, Carolyn, Bill, and Dr. Parnell. Let's get started. We ended our first podcast conversation talking about data. There are likely many board members listening to this podcast that are not yet having conversations around the social needs of their patients and broader social determinants in their communities. How do you recommend they get started? And Dr. Parnell, perhaps we can start with you.
Thanks, Priya. Let me just maybe recap a little bit from the first part of the podcast. Now, as board members, again, we are the eyes and the ears of the communities that we serve. And that boards are to govern and not manage, and put it in a different way, we're the eyes in and hands out. That being said, the board should be asking questions of management about the social determinants of health, specifically for their community. The conversation should be centered around data, again, for your community, if you will. If your system does not have a separate entity like Parkland has a Parkland Center for Clinical Innovation, I think one of the good places to get started is with a community needs assessment. The Affordable Health Care Act requires that nonprofit hospitals do a community needs assessment. Sometimes that can be somewhat stressful for some organizations that may not be large enough, so you may want to include be a whole region, if you will, because the needs for that region will probably be included, and that makes it a little bit easier to manage. And I think if you're due for a community needs assessment, and community needs assessments are not always the same, I think as board members, we should be asking management, said we want to include social determinants of health in the community needs assessment so you can get data that's specifically for your community. I think that's, to me, it's all about data and being able to understand that data to move forward. And I think as board members, we should be thinking about that again. We are the eyes and ears of our communities. I think, Bill, how you guys address this in your community?
Well, it's interesting, again, rural versus urban. When it became known that our board was interested in social determinants and playing a role, we had one of our internal medicine physicians reach out to us and mention that she was doing some work with some local producers, and she was trying to connect some of her patients who had one or more chronic diseases and self-identified as being food insecure trying to connect them with local farmers and getting them with some healthy fruits and vegetables and proteins, so that those individuals could start to address those chronic diseases by enhancing both food access and the quality of the food they're eating. And in the middle of Iowa, there are lots of places where you can get fruits and vegetables and nuts and protein, and have it delivered to your front door. And in fact, what we did is we supported that physician. We put together a pilot initiative. She is tracking the impact of the change to, in essence, a half of a CSA share. And if you don't live in a rural community, CSA is community supported agriculture, and you might get a bag or a box or a carton of fruit and vegetables every week. And what we have done is we've connected those individuals that this internal medicine physician is treating, providing them with access to these fruits and vegetables, and just as importantly, helping them with how do you prepare it? What is it that I'm going to do with a rutabaga that's going to make it delicious and good to eat, and taking that next step? And we have lots of partners as we do that, but I think the important thing is we are working with that physician who's generating data, who's going to be able to go back to these patients and future patients and say, here's what happens when you eat better, and share with policymakers, here's what happens when folks have enough to eat.
Thanks, Bill. And as you take on this work, we know that hospitals can't do all of this alone, and that collaboration with other stakeholders and community members is going to be necessary. As trustees, how involved are you in those conversations or decisions around who the hospital will partner with on this work? Carolyn, can you share some experiences there?
I certainly can. And I want to just stop and pause for a minute, because we've thrown around several phrases, and I think that they're all important as we think about who we work with and what we're trying to accomplish. We've talked about population health, community health, and social determinants of health. They're all important and key components for how we work within our communities to raise the quality of life, the health, and the well-being of the communities. And so when we think about who we're going to work with as partners, we need to think about all of those elements so that we can incorporate them into what we do as a health system within the context of our county. So we have joined forces with 30 other community partners to create a health collaborative called Live Well Lancaster County. This is the organization that we work with to do health assessments on a county-wide basis together to prioritize and address the health needs as well as the community's needs. This is what we use to meet, as Winfred talked about earlier, the Community Health Improvement Needs Assessment. So we work with this Live Well Coalition to collect a lot of data, multiple data points around morbidity and mortality data, as well as adult behavioral risk, youth surveys, demographics, social needs, and community health stakeholder surveys. From that, we are able to come up with a whole list of community needs and community indicators. What's important for us as a board is that we have a board committee called our Mission and Community Benefit Committee, which really does the oversight of all of our community benefit activities. So the data that's collected through this community needs assessment and is aggregated by the staff within Lancaster General Health, we have a community health and wellness department, will bring this forward to the board committee. Now, what's important is that this board committee isn't just made up of board members, but of key members of our community who are part of the community partners that we have joined forces with. And so we're able to talk at this board committee about what it is that we found, and what our priorities should be as we move forward. And so we create a series of community indicators, some goals, and then we monitor how well we are addressing those goals and where we're meeting them as a committee and then as a board as a whole. This leadership commitment is pretty important, we think, for how we go about understanding what we have in the community and don't have, what we need to do, and then how well we are meeting the needs that we are doing. There are three key summaries I can say of all of that. Partnerships are powerful. The partnerships are built on trust and the work that we do together. And then we measure our projects and the impact they're having and share the results with all the partners and with the public and the community at large. That's how we go about looking at, as trustees, what we think we need to be engaged in. And I'll turn it to Bill to talk about how they're handling that in his community.
Carolyn, it's remarkable. Different scope, different scale, different sized region as far as population. But in fact, we're doing something very similar in our small town. We're calling it Healthy Grinnell. Grinnell, Iowa is where we're based. And this was something driven by the board, and yet it includes the Chamber of Commerce. It includes county public health. It includes the local community service agency. It includes the faith community. It includes some senior living facilities as well. And we're pulling in those partners and those folks, as we've talked about previously, who are on the ground, who are doing amazing things and delivering services, and we're supporting them. We have been able to secure a little bit of HRSA funding in the form of a grant to expand on that pilot project I mentioned earlier, as far as individuals who have a chronic illness and who self-identify as food insecure. We've also gotten some support from a local foundation who have allowed us to target on another end to K through 12 students who identify as food insecure, and doing that in a way that allows them to maybe avoid some of the distress that comes with being seen at school by your peers as being food insecure. So by pulling these partners, by having the business community involved, by having some of the senior living and facilities and folks across the board, those sorts of partnerships, as you mentioned, Carolyn, that's how you get things done, whether you're in a big city or a small town. It's by having lots of folks working on the same team, going in the same direction. And then, Carolyn, I think the key for you is being able to quantify what's happening, being able to measure it. And that's something that we're still struggling with. But again, we're very early in the process, and we're hopeful that we can start getting a way to quantitatively rather than just qualitatively measure what we're doing.
Thanks, Bill. And I just want to reiterate the point that you made about how all three of your hospitals are very different, yet the approaches that you're taking to address the social needs of your patients and the social determinants of your communities are all on the same track, and you're moving in the same direction. And I think it's so interesting and fun from my perspective to hear this conversation and to see that that is happening in hospitals across the country. Before we wrap up this podcast, as trustees and as hospitals are taking on these conversations, why do you think that they're important and may even be more important as we move into the future? Dr. Parnell?
Thank you, Priya. Again, I'm really impressed with my colleagues here. They have different approaches, but I think we're all getting there. I think, to me, if nothing else, or for no other reason, CMS has recognized the impact of social determinants of health when they're including that in their overall care of the patient. Let's just talk about some examples. CMS has now got about 12 what we call accountable healthcare community grants that they've given to look at this particular issue as it relates to cost and quality of care. at the Parkland Center for Clinical Innovation, we've received one of those grants because we are using social determinants of health with that strong database that we created to have bidirectional communication between the clinical aspects of healthcare and the community-based organizations. So let's try to put this in some perspective by just using the example of what we are capable of doing. Let's just say that we have a patient who's in our system who shows up at a church food pantry to receive food. That pantry can then recognize that this patient is a diabetic and then say, oh, by the way, we're going to offer you this type food. In addition, oh, by the way, Ms. Jones, you missed your appointment for your mammogram last week, as well as you may have missed that appointment for that diabetic foot clinic. That's bidirectional communication, because that information will be seen when that person shows up at the clinic for that foot visit, for the foot care. They'll notice that that patient was seen in that church's food bank. So if this works out the way we kind of think it will, and CMS confirms what we know, your hospital may be reimbursed based on some social determinants of health. And as board members, again, we are the strategic eyes and ears of our organization. So I think that we should be skating to where the putt's going to be as opposed to where the putt is today. Now, I want to maybe add one more example, if I can, about some things that we have done in terms of working with a health plan. Parkland has a health plan, and they were having problems with kids with asthma showing up in the emergency room and things of that sort. We were able to give the most high-risk patients who were showing up in the emergency room over and over again text messages, and we send text messages to them. And we saw, in particular, one patient was showing up over and over again. We were able to see this with the data that we are collecting, because we have data in the schools, in the primary care clinics, and all that data gets fed back into the PCCI system, and we were able to identify this patient. We were then able to get a caseworker to go to that person's home, single parent, recognize that this kid was sleeping on a mattress that had mold that was creating the problem of having him go backwards and forward to the emergency room with asthmatic attacks. Well, what happened was we would then, the caseworker then put that patient, or that mother of that patient, in contact with another community resource that allowed them to bring a new mattress into that home, and that kid has not showed up in the emergency room since. Over that period of time, over 4 years, we have been able, PCCI has been able to decrease the asthma cost by almost 50% for the particular group of people that we were working with, and actually saved the health plan $18 million of direct cost savings in that period of time. So that's, having that community base and with the social determinants and connecting the communities has been really important in how we can do health care. And CMS is looking at it, so obviously they have some concerns about it. And one other thing I'd like to plug before I leave is that, the PCCI management team has taken a different step in that they have gone and, for organizations who have not worked with, been embarked on this journey of social determinants of health and connecting them to the healthcare system, we have now written a playbook for connecting communities with the healthcare system. And that playbook is available. And so just a way to get started, and I would say to board members, that may be an opportunity. So in closing, for me, I would say that what we need to do as we move forward, we need to have the data to make informed decisions about the quality and cost of care in our communities, and recognize that the social determinants of health is one of the driving forces that will help us make those decisions. So again, we need to skate to where the putt's going to be, and we're the eyes and ears of our communities. And with that being said, Carolyn, tell me what you guys are doing and what your thoughts are in this arena.
Winfred, that was very helpful, and I'd like to be able to say that we're all attempting to skate to where the puck is. For us, foremost is the importance of committing to the community health improvement and making it the work of our organization and part of our DNA, rather than viewing the work that we do in the community as a collection of projects or initiatives, we want to make it integral to who we are, what we are, and what we'll continue to do into the future. We think that this is essential because it takes decades to impact community health priorities and requires that community health be built into all of our ongoing strategic priorities. I've already spoken about the importance of partnerships and that they cannot be overestimated. That for us, they're the foundation of our community benefit initiatives. And I think as we look to the future, working collaboratively in a community, in a county, in a city, really is the way that we can all have meaningful, sustainable impact on our community's health and well-being. For us, it's critical for our hospital and health system as a whole to recognize that we are on a journey that has no end. And to that, we continue to look at our community. We have just completed another 3-year community health needs assessment and have found that our greatest needs in our community continue to be access to care in general, family sustaining incomes, accessible transportation, affordable and quality housing, safety from violence and adverse child experiences, and food. And so we're embarking on a decades-long project to work within our county with the city and county government to do lead abatement of all of the buildings within the city and the county. We're a fairly old city, and it was remarkable to us, coming from our primary care practices, the pediatric part, to see how many children had lead in their system. And so it became for the board a very lengthy conversation about how important it would be to do full lead abatement. That project was supposed to kick off this summer, and unfortunately the COVID-19 epidemic has slowed us down in that it is difficult to go into people's homes and displace them during this epidemic. But we intend to begin that as soon as it's safe for everyone. Bill earlier talked about food insecurity and nutritional needs that they're developing in his town and community. And we too find that that's an important project that the board is fully endorsing. And so we're working on expanding our food pharmacies and the primary care physicians' nutritional programs. Rather than having people get baskets of food directly from farms, which we can also do because even though our city, Lancaster, has a lot of farms in the county, we're also working on making sure that there are nutritional fresh foods in our corner stores in the city. You know, historically, those stores have had canned and processed products. We're working with those store owners to make sure that they have fresh food, and of course, working with our food banks to do that. The issue for us also is leveraging the full resources and influences of Lancaster General Health to create change by becoming an economic anchor institution within our county so that we can provide significant financial investment and purchasing emphasis within the county, as well as support for these community health improvement projects. We're identifying local, ethical, and diverse businesses so that we can leverage the supply chain to help build local wealth and ultimately impact local health. Those are just some of the ways that we see the future of how not only will we be providing the clinical care that we do within our inpatient and ambulatory programs, but also working on improving the quality of life and the quality of overall health of all the residents in our county. I'd like to leave you that we recognize that there's also so much more to be done in all of these areas. And the most important question that we as a board ask ourselves is what's next? Where do we go from here? And how do we continue on the journey that never ends to make sure that our community is as healthy as it can possibly be? So those are the future activities and lessons we think that we'll be employing in our county as we go forward. And I think it matches what Bill and Winfred have both spoken about.
Yeah, thanks, Carolyn. I agree with you. And it is a long journey ahead. And as you stated, where you start is looking at what comes next. And it is so inspiring to see the journey that all three of you are on in addressing the health needs of your communities. So Carolyn, Bill, and Dr. Parnell, I can't thank you enough for joining us and sharing your experiences and insights on this important topic. I think this is going to be extremely helpful to our trustees as they have these conversations now and into the future. So thank you again, and back to you, Tom.